Despite significant advancements in the diagnosis and treatment of acute coronary syndromes, cardiovascular disease is still the leading cause of death globally. Almost half of these deaths are due to ischemic heart disease. Ischemic heart disease accounts for 12% of disability-adjusted life years lost annually worldwide. In-hospital mortality rates for patients with STEMI complicated by shock remain high, especially in cases of cardiac arrest. Unstable angina is the least severe end of the acute coronary syndrome spectrum, characterized by symptoms suggesting acute coronary syndrome but without biochemical evidence of myocardial infarction. Type 1 myocardial infarction, caused by atherothrombotic coronary artery disease, is classified as NSTE-ACS or STEMI based on ECG findings. It requires a rise or fall in cardiac troponin level, or another biomarker if CTN is not available, accompanied by clinical evidence of ischemia. Myocardial injury and infarction can result from various processes, including Takotsubo cardiomyopathy, myocarditis, and supply versus demand mismatch. Type 2 myocardial infarction, which results from myocardial oxygen supply versus demand mismatch unrelated to acute atherothrombosis, tends to have a higher mortality rate than type 1 myocardial infarction. The previous paradigm of coronary atherosclerotic plaque rupture as the singular cause of STEMI or non-street segment elevation acute coronary syndrome has been disrupted. Acute coronary syndrome can be caused by plaque erosion rather than rupture, or less commonly, a calcific nodule leading to thrombus formation. Two particular scenarios of interest are 1. The presence of a clinically diagnosed myocardial infarction with no obstructive coronary artery disease identified on angiography, referred to as MNOCA, and 2. Spontaneous coronary artery dissection, SCAD. MNOCA, seen in a minority of acute coronary syndrome cases and more common in women, carries significant diagnostic and therapeutic uncertainty. The combined use of intracoronary optical coherence tomography and cardiac MRI can identify a mechanism for the myocardial infarction in most patients. SCAD refers to an intimal tear leading to creation of a false lumen in the arterial wall in the absence of a clear mechanical cause. It can result in ischemia in the subtended myocardial territory. It causes fewer than 5% of all ACS, but proportions are higher in certain populations, such as women who are pregnant or postpartum. Optimal management of SCAD is uncertain due to the absence of randomized trials, but conservative medical management and aggressive secondary prevention, including blood pressure control, is generally preferred. The possibility of a primary vascular syndrome such as fibromuscular dysplasia should be considered in these patients. Diagnosis of acute coronary syndrome relies on clinical presentation, ECG findings, and biochemical evidence of myocardial injury. The immediate initial branch point for a patient with possible acute coronary syndrome is the presence or absence of diagnostic ST segment elevations on the 12-lead ECG. Diagnosis of NSTE-ACS, which encompasses unstable angina and NSTE-MI, has evolved significantly with the development of high-sensitivity troponin assays. Adjunctive diagnostic tools, such as ECG or cardiac MRI, can help detect regional wall motion abnormalities and other evidence of myocardial ischemia in patients with suspected ACS. Physical examination findings are not generally specific for the diagnosis of acute coronary syndromes, but careful patient evaluation is critical for immediate risk assessment, recognition of impending hemodynamic collapse, and identification of mechanical complications of myocardial infarction. Tachycardia, a narrow pulse pressure, hypotension, and signs of congestion or inadequate perfusion are all indicators of high clinical risk. The Killip classification stratifies patients with acute coronary syndromes based on the degree of clinical heart failure, ranging from no evidence of congestion, Class 1, to cardiogenic shock, Class 4, and strongly predicts mortality. Mechanical complications of myocardial infarction are typically accompanied by abrupt hemodynamic deterioration along with specific physical signs. The evaluation of suspected acute coronary syndromes is challenging given the time sensitivity, potential underlying life-threatening pathology, and often nonspecific findings on initial assessment. The ECG in NSTE-ACS may show T-wave inversions or ST segment depressions, but these findings are commonly absent and are not necessary for diagnosis. Elevated concentration of a circulating marker of myocardial necrosis such as cardiac troponin I or T, CTNI or CTNT, or creatine kinase myocardial band, CKMB, differentiates NSTE-ACS from unstable angina. High-sensitivity troponin assays are sensitive and reasonably specific and are therefore preferred over other biomarkers, including CKMB, for the diagnosis of NSTE-ACS. Immediate therapy for patients with NSTE-ACS includes administration of a loading dose of aspirin and systemic anticoagulation. The optimal timing of catheterization in NSTE-ACS is a topic of ongoing debate. Clinical risk stratification is the major determinant of timing, with very high-risk patients warranting emergent, that is 140, should undergo catheterization within 24 hours. Patients at low risk should be submitted to a selective invasive strategy. Increasing evidence supports the importance of early catheterization in the highest-risk patients and generally supports the safety of delayed catheterization in lower-risk patients. P2Y12 inhibitor pretreatment before catheterization is not recommended as a routine strategy in patients with NSTE-ACS and a planned early invasive strategy. Non-invasive anatomical assessment via coronary computed tomography angiography might be expanded in the future. For patients who manifest ST segment elevation diagnostic for STEMI, emergent reperfusion therapy remains the immediate priority, as emphasized in the most recent European and American guidelines. The latest data continue to reinforce the association between prompt, that is less than 90 minutes, reperfusion and more favorable long-term clinical outcomes. Patients presenting to a percutaneous coronary intervention PCI-capable hospital should undergo immediate coronary angiography with a goal of first medical contact to device time of less than 60 to 90 minutes. For patients presenting to a non-PCI center, transfer to PCI should be executed if the anticipated time to PCI will be 120 minutes or less. If PCI within this timeframe is not possible, fibrinolysis should be administered if not contraindicated, and a pharmaco-invasive approach should be considered. About half of patients with STEMI have obstructive coronary disease outside the infarct-related artery, and the presence of flow-limiting non-infarct-related artery lesions portends a worse prognosis. The complete trial found that patients with hemodynamically stable STEMI and at least one other significant non-culprit lesion who underwent complete revascularization of all lesions within 45 days had a lower rate of cardiovascular death or myocardial infarction compared with culprit-only PCI. Providers should anticipate planned staged revascularization procedures in many patients discharged after STEMI. These subsequent procedures heighten the importance of antiplatelet therapy adherence and can create further need for follow-up visits and renal function assessment. The complete trial findings cannot necessarily be extended to patients with acute myocardial infarction, STEMI or NSTE-ACS, complicated by shock. In the culprit shock trial, patients with acute myocardial infarction with shock and significant non-culprit coronary lesions who underwent immediate multivessel PCI had higher rates of renal failure and death than those who underwent culprit lesion-only PCI. Routine immediate non-culprit lesion PCI is not recommended in these patients. Whether staged revascularization after resolution of the shock and concomitant end organ injury may be beneficial is not currently known. Antiplatelet therapy is a critical component of the medical regimen in the acute phase of acute coronary syndromes as well as for secondary prevention following stabilization. Previous randomized trials have shown that treatment with aspirin plus a P2Y12 inhibitor for at least 12 months following acute coronary syndromes reduces ischemic events, with additional benefit seen with the third-generation P2Y12 inhibitors ticagrelor and prasugrel compared to clopidogrel. These reductions in ischemic events come at a cost of increased bleeding, but with an overall favorable net outcome in the pivotal trials. DAPT has typically been recommended for 12 months following acute coronary syndromes in patients not meeting criteria for high bleeding risk, with ticagrelor and prasugrel generally preferred over clopidogrel. The approach to antiplatelet therapy in the setting of ACS is evolving, with major areas of recent new clinically relevant data being choice of agent, early aspirin cessation, and strategy in patients with an indication for an anticoagulant. The ISAR REACT-5 trial provides the only major randomized comparison of prasugrel versus ticagrelor in acute coronary syndromes. The 2020 ESC NSTE-ACS guidelines provide a Class IA level of evidence B recommendation for prasugrel over ticagrelor in patients with NSTE-ACS who undergo PCI and are eligible for prasugrel, no prior stroke or transient ischemic attack. The intravenous P2Y12 inhibitor cangrelor is an additional option in the acute phase for patients undergoing PCI who have not been pretreated with an oral P2Y12 inhibitor and who are not receiving a glycoprotein IIB/IA inhibitor. The potential utility of genetic or platelet function testing to guide P2Y12 inhibitor choice has also been a topic of renewed interest. The Popular Genetics trial found that among patients undergoing primary PCI for STEMI, a genotype-guided strategy with de-escalation to clopidogrel in subjects without loss of function CYP2C19 alleles was non-inferior to standard therapy for ischemic outcomes and had a significantly lower rate of bleeding. Conversely, in the Taylor PCI trial of patients undergoing PCI for acute coronary syndromes or stable coronary disease, a point-of-care genetic testing strategy had no effect on clinical outcomes at 12 months. Clinical assessment of ischemic and bleeding risk remains the cornerstone of agent selection. The Twilight trial investigated early aspirin cessation post-PCI, percutaneous coronary intervention, among 7,119 patients, most of whom had NSTE-ACS, non-ST elevated acute coronary syndromes. Patients received aspirin and ticagrelor for 3 months post-PCI, then were randomized to either ticagrelor monotherapy or continued DAPT, dual antiplatelet therapy, with aspirin and ticagrelor. The trial found lower rates of primary bleeding at 1 year with ticagrelor monotherapy, but no difference in rates of ischemic events like myocardial infarction and stroke. However, the trial wasn't designed to assess these outcomes. Other trials and a meta-analysis with over 32,000 patients similarly found no increased risk of MACE, major adverse cardiovascular events, with early discontinuation of aspirin, even in acute coronary syndrome patients. The trials didn't focus on evaluating the impact of early aspirin cessation on specific medication-intended outcomes, such as myocardial infarction, stent thrombosis, and stroke. Data beyond 1 year is limited. Balancing these findings with previous trials showing benefits of extended duration, greater than 12 months, ticagrelor, prasugrel, or clopidogrel on top of aspirin therapy is challenging. The collective trial data suggest that most patients might not face a significant ischemic risk when transitioning to P2Y12 inhibitor monotherapy after 3 months of DAPT. Recent NSTE-ACS guidelines consider this strategy acceptable in patients with high bleeding risk. There's limited data on early single antiplatelet therapy, SAPT, with only aspirin. But in the MASTER DAPT trial, 1 month of DAPT wasn't inferior to at least 3 months of DAPT in terms of net adverse clinical events in high bleeding risk patients undergoing PCI with drug-eluting stents. About 30% of these patients received aspirin alone after 1 month of DAPT. Around 8 to 10% of patients undergoing percutaneous coronary intervention, PCI, also require an oral anticoagulant, typically due to conditions like atrial fibrillation. The use of triple antithrombotic therapy, comprising dual antiplatelet therapy, DAPT, and an oral anticoagulant, has raised concerns about excessive bleeding risk. The 2020 ESC NSTE-ACS guidelines recommend 1 week of triple antithrombotic therapy, or until hospital discharge, by default, followed by dual therapy with a DOAC plus P2Y12 inhibitor, usually clopidogrel, until 1 year, after which DOAC monotherapy may be considered. The duration of triple antithrombotic therapy could be extended to 1 month in patients with high ischemic risk and acceptable bleeding risk. Assessing a patient's risk for clinically significant bleeding is vital when considering antithrombotic strategies after acute coronary syndromes. The ESC suggests the use of the precise DAPT scale or the ARC-HBR criteria for evaluating bleeding risk, with a precise DAPT score of 25 or more indicating high bleeding risk. However, as of now, there is no high-quality randomized data supporting the use of any specific bleeding scale in determining antithrombotic strategy. Secondary prevention after an acute coronary syndrome is crucial. Lipid-lowering therapy significantly reduces the risk of adverse cardiovascular events. Apart from statins and ezetimibe, additional classes of lipid-lowering agents are showing promising results. Monoclonal antibodies against PCSK9, evolocumab and alirocumab, which reduce LDL-C by 50 to 70%, have shown significant reductions in cardiovascular events in high-risk patients, including those within 12 months of acute coronary syndromes. The EVOP-ACS trial studied in-hospital initiation of evolocumab in patients with acute coronary syndromes and elevated LDL-C and found rapid attainment of guideline-recommended LDL-C levels. The ESC guidelines recommend a stepwise approach of starting all patients with acute coronary syndromes on high-intensity statin therapy. Patients not achieving LDL-C concentration of less than 1.4 mmol/L in 4 to 6 weeks should additionally be treated with ezetimibe. If the LDL-C remains above this level, a PCSK9 inhibitor should be added. For patients who have had a recent acute coronary event within 2 years of a previous one, an LDL-C goal of less than 40 mg per deciliter may be considered. American guidelines recommend a treatment LDL-C threshold of 70 mg per deciliter for high-risk patients, above which non-statin therapy should be added to further reduce LDL-C. Inflammation has been observed to increase the risk of recurrent events following acute coronary syndrome. Anti-inflammatory treatment with colchicine has shown some promise, reducing the risk of MACE by 23% in the COL-COT trial. Similar findings were observed in the LODUCO-2 trial. However, colchicine-treated patients in these trials had numerically higher rates of non-cardiovascular death. The COPS trial found a significantly increased risk of death with colchicine. And that brings us to the end of today's learning session. If you found this video useful, don't forget to hit the like button. It truly helps us out and keeps us motivated to produce more content. Remember to subscribe and hit the notification bell so you won't miss our upcoming videos. We upload regularly and we wouldn't want you to miss out on any valuable learning opportunities. If you have any questions or topics you'd like us to cover in future videos, please leave them in the comment section below. We always appreciate your feedback and we're keen to know what you think. Remember, learning is a continuous journey and we're glad you chose to walk this path with us. Until next time, keep learning, stay curious and we'll see you in our next video.